Hey,
Hi,
hello,
everybody.
hi everyone. I'm Dr. Akram, one of the intensivists at HPMC, and also I specialize in in medicine, infectious disease, and nephrology. It's kind of rare.
Wow.
Hello.
Dr.
So what are you?
Dr. Akram,
Yeah.
this is called the Clinical Scoop, and welcome. We have Dan and Monica with us here, and they're going to be showing us some slide about new studies for COVID-19, and we'll
Okay.
try to discuss it and give more information for the audience in this meeting and to see. This is the first
Okay.
study about anticoagulation in critically ill patient with COVID-19.
It is very important, I think, particularly in this particular disease. I always use therapeutic dose and full anticoagulation as if I'm treating DVT or PE.
This is very, very relevant study for the COVID-19 because they found out in China, in Wuhan, when they were treating the patient with anticoagulation, their survival is much better. Now, in United States, they're trying to put a clinical trial for that and comparing different doses of anticoagulation. They found out that using enoxaparin or Lovenox subcutaneously as in different dosing as 0.5 milligram per kilogram for every 12 hours versus every 24 hours to compare the survival for the patient. The primary outcome measurement they want to see in the intensive care unit setting, the 30-day mortality rate. Secondary outcome of the study is length of the intensive care unit if using the anticoagulation will be shorter, and number of veno-occlusive events that happen in this. Okay, so that's the main study. I think it's a valuable study, and it is very helpful study for the population that get affected by COVID-19 and for the medical field in general in treating and dealing with. What do you think, Dr. Akram?
I agree with you. In fact, I read some post-mortem studies of COVID cases, and they were surprised to find so much of clots, and it's also inflammation of the endothelium. Vascular inflammation is very common and rampant in COVID-19. So I think it'll be a valuable study, and also I think we need to anticoagulate these patients for sure.
I think the problem with the problem in the anticoagulation is that's the bleeding, and as a physician, you need to weigh the risk of the bleeding to the risk of benefit of anticoagulation on these patients. I think Dr. Akram have a lot of experience with this through his patient in the intensive care unit and dealing with the bleeding in the ventilator or off the ventilator.
Yeah. So what I generally say is that bleeding can be controlled, but the clot can kill you without even have a chance to do anything about it. I have seen patients who had stroke and MIs, and at the same time COVID. Maybe COVID made them worse, generated more clots, and that can happen as well. But in general, I would definitely, there is a risk for bleeding when you start full anticoagulation, but I think the risk for clotting and that causing events are more life-threatening.
What do you think about the design of this particular study? As a doctor, if you were offered this study in your hospital, would you take it, or do you have any complaints about this kind of study?
Well, so the different doses of anticoagulation and there are different medications people have used. For example, people are using new oral anticoagulants as well. So in this situation, it is good study to compare one or the other. We have done that in atrial fibrillation and a couple of other diseases. I don't know how this will pan out in COVID-19. So this is new knowledge for sure. and it's and we are learning so much about this disease, the hundreds and hundreds aspects of it, and I think this is one aspect. I definitely would look forward to the results.
Dan, I think this study is done it's done very well, and the randomization between one medication in different doses, which is the Lovenox, in comparison to other medication like Argotroban and Lovenox and Fendoxapinix.
In 30 days, you're saying 30 days is the outcome, right? And I think that's reasonable, 30 days. But I feel that it may also be, the events may occur beyond 30 days as well. So I'm sure somebody may be following up on that study of 6 months or so, I suppose.
Yeah, I think so. It's 6 months follow-up, and this is also phase 4 study. So
yeah, because I see that after effects are still going to be there in a COVID situation in this particular disease. Yeah.
You know, oftentimes for studies, the criticism that a lot of clinical research studies get is that the inclusion-exclusion criteria is not realistic of the real world. So from this one, I mean, the inclusion seems pretty easy, but the exclusion, do you find any issues with the exclusion of this particular study?
Yeah, can you just read a little bit for me from the slides what the exclusion criteria?
Objectively documented deep vein thrombosis or pulmonary embolism. These are all the exclusions. Patients in whom there is very high suspicion for pulmonary embolism and are on full dose anticoagulation. Platelets of less than 30,000, not due to DIC based on the International Society, and then active bleeding that possesses a contraindication to therapeutic anticoagulation, history of bleeding diathesis, so history of intracranial hemorrhage in the last 90 days, history of stroke in 2 weeks, major neurological procedure in the past 30 days, cardiothoracic surgery in the past 30 days, intra-abdominal surgery in the past 30 days, intracranial malignancy, patients who require therapeutic anticoagulant for other reasons like atrial fibrillation. Anything wrong with those, or that's pretty good for the real world?
All of those appear great, but in the real world situation, one thing I may say about that observation is patients come to the hospital and they have a clot, they have a DVT, and then we start anticoagulation in general. So what you're doing when you exclude those is kind of slightly more, you're trying to show that you have to prevent the DVT events. So that decreases I think the power, you might have to have a power of the study might be decreased. You might have to have a number of patients you might need more.
Yeah.
So if you include the patients who have a DVT, it's okay to me. It's not bad, because once you start heparin, Lovenox, immediately the clot stops growing. And that itself is a proof that it's working. And I would not have worried if they included some patients with DVT, but it just decreases the strength of the study and a lot of number of people that we may need to prove that.
Yeah, see, it's not that surprising, and we'll go to the next study, but it's not that surprising because that's one of clinical research's biggest criticisms is the inclusion-exclusion criteria is not reflective of the real world. And so a lot of new doctors, when they're new to research, they always tell the sponsor, we can enroll 100 patients, because they don't pay attention to inclusion-exclusion. And then when they're doing the study, that 100 patients becomes 5 patients. And now the sponsor is worried why they're not enrolling more. Yeah, and so this is the problem.
Everything else is all we do except one of that. That's my observation. That will help. That will kind of make it more difficult for you to really prove at the end. So.
Yep. So Dr. Al, what can you see the screen here for this second study, or Monica? What do you guys think about this one?
I asked Monica to read a little bit for me, but I can open it.
This is a phase 2 trial of Infliximab in coronavirus.
Go ahead.
Go ahead. I'm looking at it now. So.
So this one is we hypothesized that early institution of TNF-A inhibitor therapy in patients with severe COVID-19 infections will prevent further clinical deteriorations and reduce, one second, this part I can't
Yeah, I
read
think
it.
I'm back. My video was a
This
little
one
bit
is
off.
only,
Yeah.
this one is interesting, only 17 participants they
17
want.
patients, yeah.
So interventional, this is only going to be one site. The other study was 180 patients, and only on one site. That was Cornell. We forgot to give them a mention. Cornell. This one is, anybody can contact them too. Their email is there. This one too. We can call Christian Lawler and ask him questions, but he's from Tufts Medical Center. So he's the contact, and the PI is Dr. Matthew at Tufts. What do you think about this? IE?
Remind me again, Infliximab is going against which medicine for now? Or is just, tell me a little bit about Infliximab.
All patients enrolled in this trial will be assigned to Infliximab arm. Patients will be
what
treated.
about the other control arm?
They are going to compare two different doses of Infliximab.
Yeah, but what about Infliximab alone versus tocilizumab or remdesivir? Is there anything else that is there to compare?
No, Dr. Akram. No.
Not in this study. No,
not in this study.
And they suggest that interleukin-6 or inhibitors or something decreases the inflammation and it might work. That's one. So
mainly, Dr. Akram, they're looking for the oxygenation of the patient as the primary end result of the study. Outcome is the time to improvement of oxygenation, time from 28 days.
By inhibiting the TNF alpha, I see.
Exactly, as Remicade used.
So, I have noticed that definitely when the COVID was at its peak, like in March and April, we tried everything, but the oxygenation did not improve, and a lot of the patients died. But there is definitely a time pattern which is slightly different from ARDS due to bacterial infections, other sepsis. Definitely, that may I think has changed now since we started remdesivir. So I'm just looking at it because this is such a fast-moving field right now because everybody is doing a study. So are we going to compare it with the historical controls? Are we going to compare with whom? I don't know, because previous ARDS has a different timeline of oxygenation improvement. So
what do you think about this design of this study using Remicade by itself in different dosage for controlling the oxygenation or improving the oxygenation within 28 days of the patient hospitalization, who's on the ventilator or in acute respiratory, this ARDS, acute respiratory distress?
But do we know that Remicade alone will improve oxygenation in COVID patients? And if it does, how long does it take? We don't know that. We don't have the baseline data, isn't it?
I know, but as a TNF, tumor necrosis factor inhibitor, and affecting on the cytokine crisis that happened in COVID patient, they found some response in it, but they don't have enough data to say how long does it stay or how long does it last and does it improve, and that's what they're running the study. So
now, is there objective data such as CRP? Has the CRP gone down with Remicade? Because I've seen that happen, but that still doesn't decrease the oxygenation though. I've seen many patients where CRP came down from 36 to 2.5, 4 almost, and then but the oxygenation did not improve. So I'm kind of a little bit not so sure if you give one dose A versus dose B, it may be too early for that kind of study. But that's my opinion. But
Yeah, there's definitely a lot of these studies. What about the exclusion criteria? Is this more
Tell me about the exclusion. I can see some. You can read a little bit also for everyone.
Treatment with any TNF-A inhibitor in past 30 days, known hypersensitivity to any TNF-A inhibitor, murine proteins or any component of the formulation, presence of any of the following abnormal lab values at screening: ANC less than 1,000, hemoglobin, I can't see it here.
Less than 8.
Less than known active or latent hepatitis B, known or suspected tuberculosis or history of incompletely treated or latent TB, pregnancy, of course, intubated for more than 48 hours is an exclusion.
Why I don't know why you would want to exclude people because 48 hours. What you're looking at is the rate of improvement of oxygen. So between you can go from day to, let's say you start a study on Monday and you're looking on, let's say 3 days, 72 hours later, and you look at oxygenation or a PF ratio, whatever you want to look at, and you say from within 72 hours, it came down by 10 points, or went up by 10 points. So you would look at divide by rate. So if you're looking at the rate, I wouldn't worry about really excluding I would rather include everybody.
Why do you think they put that there?
I don't know, because maybe they think that it is too much for inflammation and the patients are too sick for that, I suppose. But that's not what we're looking at, right? We're looking at the rate, and sicker the patient, it doesn't matter. It's just the rate. Maybe actually those are the patients that it may be beneficial actually.
Right.
So, but yeah, but
that's another example of real world versus research is kind of different things sometimes.
Yeah.
The next one is fungal infections, uncontrolled, and then serious comorbidity. So they're excluding any serious comorbidity, including myocardial infarction within the last month, moderate or severe heart failure, acute stroke within last month, uncontrolled malignancy, or stage 4 chronic kidney disease requiring dialysis.
So this MI and stroke, I told you earlier about patients who may have MI and stroke about the same time as COVID. Actually, COVID is generating those, not like 1 month earlier. I haven't seen a patient who had MI like a month or 2 months earlier, because they never came to the hospital during the peak period. So actually, COVID is causing this MI and stroke. So I would say it's part of COVID-19 disease.
So that's a good point, because now you're going to have all these patients in the hospital before they are screened. So if COVID is triggering a MI or a stroke while they're in the hospital.
I would include that. I would treat the disease. I mean, we are treating it with anticoagulation. Anyway, we have proved that it causes thrombosis even in the basic science studies in pathogen in the postmortem studies or examination. So I would say, if you can recommend that, maybe that's not necessary to exclude so many people who actually might benefit from it. So we're kind of making ourselves limited, and make it harder for the study to really proceed and give you information on the real world situation.
Yeah, it's interesting how they design these studies for the biostats in mind before it's designed.
I'm hoping I'm not giving you too many points that are negative, but
No, these are not my studies. So I agree. This is the case in most studies, Doctor.
I'm not that pessimistic when it comes to studies. So
that's a good point, because when doctors do research on their own, they get offered these studies. They think that the inclusion exclusion is going to reflect their real world population, and usually it doesn't. And there's a trend that studies are getting more complex.
It reflects more the politics.
That's right. That's right.
Some of it, how you can get through the IRB and all of that.
Exactly. But some of these IRBs, I mean, the more inclusionary they are, the better, the more ethical it would be, right? But I don't know.
I mean, you can make an argument like I was thinking in these two studies. If you can,
And the third one, Monica, Monica or Dr. Al, you want to go through this one?
So third one.
High tier anti-SARS-CoV-2 plasma in hospitalized patients. What do you guys think?
Yes. See, I have used the plasma, and I'm talking about real world situation because I haven't collected the data and analyzed it myself yet.
Mm.
But this study is good and it has worked in the prior situations like other viruses, SARS, Ebola. But the problem is we don't know when the COVID occurred, who gave the plasma, and we don't know how long the antibodies last, and we don't know how many antibodies that a person makes. You know what I mean?
Mm-hmm.
And all of those are variables. So I haven't found a consistent response after giving plasma. And now we had a very small interval of time when there was only COVID plasma available, but not remdesivir. But nowadays we are just giving COVID plasma, remdesivir, dexamethasone, all at the same time, and maybe to see some changes we are seeing. But I don't know how much of it is COVID plasma, and I guess it's going to be not consistent, and because it's just we don't know how many antibodies. Some people may have only minimal antibodies, who knows, and they may not even survive.
What do you think, Dr. Al, about this?
I think it's already done in Wuhan, China, and they found that like a good response for for this kind of serum plasma for the patient who's severely ill in the ICUs. But as Dr. Akram said, how much each patient can require and how much each body can produce.
We are only giving two.
And yeah.
We don't know. And then a few days back, there was some investigation which suggested that the antibodies may be finite. So if somebody had an infection in January and he donated the blood in, say, April, I don't know if that has enough antibodies. But a lot of these are there. A lot of these real world challenges in actually identifying the quantitating the antibodies are there. So, but I would always add it. I don't stop it. Like I'm just giving it to everybody just because even if it gives an edge a little bit, like something, because it's proven to work in other viruses situations.
So this is already being done outside of research. You're doing this in the private setting.
Yeah, I'm giving COVID plasma plus whatever are available. We are just piling up, adding on one after the other. Yeah.
I think we're doing it in the community setting now for the patient that really severely ill, and if there is to see if there is any outcome we can get from them. It's not gathered data, or it's not something under clinical trial, but I think it's worth it because of this emerging field of COVID-19 now. And
I was thinking, let's say like some people have ID like perfusion centers, like hematology have like infusion centers. I think we could do it in a patient who are less sicker. I don't know. I mean, that is something we can try. Dexamethasone plus COVID plasma, outpatient setting for a patient.
Dr. Akram, I tried to do this in my clinic here, but it have a lot of regulation because it's a blood product. It have to go through a lot of outside the hospital. Have to go through a lot of authority to be approved. Okay, you need to be similar to blood bank unit to be able to do this in your clinic. But in the hospital, but in the hospital, because you already have license for blood bank, you can do it in the hospital as you're doing it now for COVID-19 patient in the intensive care unit.
Right. Well, I'm using it. I think it works, but I cannot show you I cannot tell between the differences between when we were giving only COVID plasma plus the other medications. I didn't know how much was COVID plasma causing any. So nevertheless, I think I will use it.
So this will be a study that you will be interested on doing, doctor?
Regarding with COVID plasma?
Yeah.
I would be interested, but before that, I would like to do a little bit quantitative measurements of how much plasma, how much antibodies does that plasma have. Would it be fair to say that's what is needed?
So what would be like your ideal? You're a hospitalist. I'm assuming your hospital, does your hospital do studies as well?
We don't do the studies yet, but because of the COVID-19, we are interested in doing some.
Okay.
So we are
What would
working
be
on
like for COVID-19, from all that you've done and seen so far, what would be your ideal study that you would be most interested in exploring further?
Well, because of my interest in critical care that we were doing, I was interested in really seeing the changes in oxygenation and how we are changing that. That's one of the things that I was interested in. And there are a couple of things we've just begun to gather data, but we haven't really come across a study that is we get everybody together on the same page yet. So, but
Yeah.
I believe there are hundreds of aspects still unexplored in COVID-19, and people will be writing a huge book by the end of next year in 1 year. Yeah. So any study, even you can just pick one study and just look at, for example, just look at any system. For example, how it involves the brain. Somebody said there are 3 stages of involvement: stage 1, 2, and 3. And then some are now focusing, like 6 months later, there's still some cognitive changes. And then there are study on the heart. There's, it's the ACE inhibitor, the ACE receptors are extensively present in the lung as well as in the heart. So we could measure the cardiac index outputs. We could actually do some direct attack on the ACE and ARB inhibitors in the lung, which we haven't done at all. There is no way to. I have seen that so far we haven't really changed the way the lung appears on the X-ray because the inflammation we are not able to get rid of yet. So I don't know if there's something that we can do directly by infusion or doing some bronchoscopy and figuring out the quantitative amount of virus within the lung and how it can be directly attacked. So those are things that I have in mind, but right now I don't have any specific person or a group that came forward yet. So.
Yeah. Well, maybe that's where Dr. Al and Monica and Republic of Research help out at some point. The goal is to help doctors do studies, make it easier for doctors to do studies. That's the mission. So,
good. Yeah, I think you guys have really good points. I am actually interested in doing such kind of clinical research, and so we'll be happy to continue and keep in touch and see where we can go.
Absolutely.
Yes.
And we'll have you on again. We'll have you on again as well to discuss more about COVID and your experiences. Now we're in the middle of July for everybody watching later. So what do you think? Second wave coming, or what is your expectations here?
Well, second wave will come. This particular virus is not just like flu. It's probably here to stay a little longer and may require multiple aspects, may require a treatment with multiple medications and attacking at different points of its life cycle. And so this is going to be a long-term situation. We'll see what happens. So.
Okay. Thank you very much, Doctor. We appreciate it. Thank you, everybody, as well, Dr. Al, Monica.
Thank you.
All right, Monica.
Dan, thank you, Monica. Thank you, Dr. Akram.
We appreciate you guys. Have a
Thank
good
you.
day.
Now I have